I think the other sort of set of studies are looking at sort of taking therapies that we think are effective and trying to improve upon them. One that comes to mind is the BT 8009 phase 2, phase 3 trial. There's the Duravelo-2 trial. I'm an investigator on this study, and this is a study looking at this peptide drug conjugate, BT 8009, also called zelenectide pevedotin, which may have similar activity to EV. We have to see this in a really well done, well-powered phase 2, phase 3 trial. May have less toxicity, and the thought here is that the molecule, the BT molecule, is actually much smaller, so it can penetrate the tumor microenvironment better. So maybe we'll get better activity of the drug, and it may be less persistent in the circulation because it's a small molecule and not an antibody. So you may have some less lingering toxicity, especially skin toxicity. And that seems to be borne out in the initial phase 1 trial, where we're seeing less toxicity with BT 8009. So I think if obviously we want to have therapies that work for every patient, but it takes time to develop those. And so if we can improve upon existing therapies, I think that there's something to be said for that. I think the other unmet need is really giving these therapies earlier in the disease course. And again, while we're focused on locally advanced and metastatic disease, I've mentioned already that some of these agents we've been discussing, like PD-1 inhibitors, like enfortumab vedotin, and others, are moving into the perioperative space. And it may be that can use these in the perioperative space to help prevent patients from ever relapsing after they have their bladder removed. I think lastly, there were 2 important studies that looked at in the neoadjuvant space of giving therapy but not removing the bladder. There's specifically a Hoosier-Oncology study presented about 2 years ago now at GU ASCO by Dr. Galsky, in which patients got neoadjuvant nivolumab plus platinum-based chemotherapy, and then if they had a complete clinical response, were allowed to keep their bladders. And most patients did very well in terms of not having metastatic relapse if they were in a complete clinical response. So I think avoiding cystectomy would be a great win. I think our frontline therapies in the metastatic space would be really important, and then developing novel therapies in the later line space. The last piece I haven't talked about much today is when we're treating patients with radiation in bladder cancer. Concurrent radiation therapy typically is given with platinum-based chemotherapy, sometimes 5-FU. But there are a number of studies now looking at adding PD-1 inhibitors or even EV, enfortumab vedotin, and PD-1 inhibitors or other agents to concurrent radiation as another form of bladder preservation. So we'll have to see how those studies play out, but it's pretty exciting.